In this unit, we will look at various blood disorders involving either the formed elements of the blood or the coagulation cascade. The first of these disorders is anemia. Anemia is characterized by low hemoglobin levels, numbers less than 14 to 18 grams per liter in males and 12 to 16 grams per liter in female. Hemoglobin is important because this is where oxygen binds for delivery through the blood. If there is not enough hemoglobin, this will result in a decreased ability of the blood to transport oxygen. When this happens, the first thing that occurs will be other physiological mechanisms will kick in an attempt to try and compensate. These include arterial dilation. The blood vessels will dilate. This will cause an increase in cardiac output. The ultimate goal is to try and increase the blood flow, figuring if we can deliver more blood to the tissues, this will result in more oxygen. You will also see a shift to anaerobic metabolism because this does not require as much oxygen, and the kidneys will respond by secreting more erythropoietin. Erythropoietin is a hormone produced by the kidneys, and it results in stimulating the bone marrow to produce more red blood cells. If these attempts to compensate do not restore normal oxygen delivery, or if the hemoglobin levels drop below 7 to 8 grams per liter, then you will begin to experience signs of hypoxia. These include paleness, weakness, lethargy, and exercise intolerance, all of which require oxygen to support metabolism, and in very severe cases, abnormal cardiac rhythms and hepatic necrosis can occur. This is a flow chart showing what we just had in words. Tissue hypoxia, the first thing you will see will be various compensation reflexes. If these reflexes work, then oxygen levels will be restored. But if they don't, then you will see signs of anemia. There are various tests for anemia. When we test for anemia, we're going to look at the red blood cells. We'll look at their numbers, their size, as well as the overall volume of blood. One test that can be performed is a hematocrit. An hematocrit represents the volume of cells expressed as a percent of the total blood volume. What they do is they will take a sample of blood and spin it down. The red cells are the most abundant. They will settle out or pack down, and then you measure how much of the total volume is represented by packed red blood cells. Normal number for erythrocytes is right around 45%. You can also do a mean corpuscular volume. This looks at the size, overall size of a red blood cell. And you can also look at the mean corpuscular hemoglobin concentration. This tests for the hemoglobin levels in red blood cells, and it gives an indication of the capacity of these cells to be able to transport oxygen. Using these tests, we have various terms to describe the red blood cells. A cell that is normocytic means it is the normal size or the normal volume. Macrocytic is a cell that is larger than normal or would have an increased mean corpuscular volume. Microcytic are smaller than normal red blood cells or a decreased mean corpuscular volume. A cell that is described as being normal chromic has normal amounts of hemoglobin, so they would be the normal color. If they are hyperchromic, they have increased amounts of hemoglobin. This would be an increased MCHC. And hypochromic, they would be lighter than normal red blood cells because of a decreased amount of hemoglobin represented by a decreased MCHC. One last test is to do a reticulocyte count. Reticulocytes are immature red blood cells, and they should not be present in large numbers in the blood. By measuring this, we can get an idea of the pathophysiology behind the anemia. If the anemia is due to an increased destruction of the red blood cells, you will tend to see an increase in the number of circulating reticulocytes because the bone marrow is struggling and trying to spit out cells before they are mature. If the anemia is due to an inability of the bone marrow to produce enough red blood cells, then you will see a decrease in the number of reticulocytes. We will look at the different types of anemia. Anemia could be due to a defect in the bone marrow. This is where the red blood cells are produced. It could be due to a dietary deficiency, or it could be due to some other chronic disease. Starting first with marrow defects. This would result from abnormalities either in the stem cell or in the progenitor cells. A stem cell, there is one stem cell that gives rise to all of the formed elements of the blood. Once a cell becomes a progenitor cell, its outcome has been set. And there are various progenitor cells. There's one for the red cell line, one for platelets, and several progenitors for the different white blood cell lines. To tell where the defect is, you need to look at the circulating formed elements. If only the red blood cells are affected, then it most likely is due to a defect in the progenitor or the progenitor of the red cell line. An example of this is pure red cell aplasia. This truly is an abnormality of the progenitor for the red blood cell line, but this is a relatively rare form of anemia. More likely, you will see a pancytopenia. Pancytopenia is a deficiency in all formed elements, so the abnormality must occur early on in the development process, probably as far back as the stem cell. This could be due to bone marrow suppression as the result of an infection, chemotherapy, radiation therapy, or different drug reactions. An example of a pancytopenia is aplastic anemia. Here, all normal formed element precursors are reduced. Over time, you begin to see fat cells replace them in the bone marrow. This will then begin to result in other secondary problems. You will see increase in bleeding due to thrombocytopenia. The platelets are also affected. You will see decreased number of platelets. You will also see an increase in secondary infections because the white blood cells are affected. Therapy often involves a bone marrow transplant, or it could be also involve immunosuppression if the aplastic anemia is due to an autoimmune problem. Mortality can be very high, especially in severe cases. Another cause of anemia is due to dietary deficiencies. These would be deficiencies that result in impaired erythrocyte production. One of these nutrients is iron. This would result in iron deficiency anemia. This form of anemia results when there is not enough iron to maintain erythropoiesis. Every day, we need to replace roughly 1% of all of our red blood cells because they are cleared out and destroyed on a daily basis. The good thing is that our body is a great recycler. When red blood cells are destroyed, the iron will be released from the hemoglobin and recycled to make new hemoglobin. However, this is not 100%. Some will still be lost in the urine and in the feces, as well as small amounts through our skin when we perspire. So we have to make up for this loss through diet. Women are most susceptible to this form of anemia due to the blood loss associated with menstruation. Most women are in a state of marginal iron deficiency. How do we get our iron? Best source is from animal products, meat, liver, and eggs. Iron here is in heme, and this is more easily absorbed by our body and converted into the form we need. Many people don't eat meat, so yes, you can get hemoglobin from plant sources. Nuts, legumes, and beans are a good source. However, the release of iron from these products depends on gastric acid in the stomach. This will help to form soluble complexes of the iron along with other dietary components. So it's not as easy to absorb the iron from plant sources. The good thing is we store iron. Any extra absorbed iron will be stored in the intestinal epithelium, in the liver, and in macrophages. When iron intake is reduced, our body uses these stores to supply the bone marrow. When these stores become depleted, then you will see signs of anemia. What would be some causes of a deficiency? One would be inadequate iron in our diet, that we're not replacing what we lose on a daily basis. It could be an absorption disorder, that the body is not able to absorb the iron from our diet. It could be a blood loss. Usually this is the result of GI bleeding. A small GI bleed can deplete our iron stores without even coloring the stool. And a very heavy menstrual flow in women. How would this manifest itself clinically? The red blood cells would be microcytic and hypochromic, smaller than normal and very pale, hence a low MCV, low MCHC. Another dietary material that's very important is vitamin B12. B12 is needed for normal DNA synthesis. Without B12, you will see suppressed hemopoiesis, and this will result in a pancytopenia. All formed elements will be involved. RNA and protein synthesis will be normal in these cells. So what you end up seeing is that the cells will grow, they will get bigger, but they are not able to divide. This form of anemia is often called megablastic anemia because we see these megablasts in larger than normal red blood cells. Clinically, it would show as being macrocytic and normal chromic, larger than normal red cells, but with the normal amounts of hemoglobin. On the surface, this may sound great. The red cells have the normal amount of hemoglobin. Where's the anemia come in? However, these enlarged red blood cells are seen as abnormal by the body. They will be very quickly cleared from the circulation, and this is what causes the anemia. Where does B12 come from, and how do we get it? B12 is also known as cobalamin. We get this from meat, liver, seafood, and dairy products. We only need roughly 1 microgram of B12 a day. And the good thing is we have stores of between 2 and 5 milligrams, so our bodies can survive a long lack of dietary intake. The problem with B12 is its absorption. Before B12 can be absorbed, the released B12 from food must combine with a glycoprotein called intrinsic factor. Intrinsic factor comes from the parietal cells in the gastric mucosa of our stomach. Intrinsic factor plus cobalamin then pass to the intestines. Here they will bind to receptors on the epithelial lining of the ileum and then be absorbed. They can only be absorbed after they bind. Once absorbed, B12 must be released into the blood. This is done through another material called transcobalamin 2, or TC2. This will release B12 from intrinsic factor, and then B12 combines with the TC2. B12 then travels in this way through the blood and will be taken up by the bone marrow. So then how do we get a deficiency? What are some causes of megablastic anemia? Usually it's the result of a defect in absorption. One defect is known as atrophic gastritis. The absorption here is hindered by a lack of intrinsic factor. This could be due to an autoimmune attack of intrinsic factor or that the parietal cells just don't make it. This is more commonly referred to as pernicious anemia. Another cause of absorption problems could be resection of the ileum. This is where B12, the majority of B12 is absorbed. So if a portion of the ileum has been removed, there's less surface area for absorption. Then it could be due to abnormal bacterial growth in the intestines or due to a tapeworm. In these last two examples, the organisms are using up the dietary B12 before we have a chance to absorb it. So it's all used up before it can be absorbed. Another effect of B12 deficiency is the presence of neuropathy. This involves both the central nervous system and the peripheral nervous system. This is the result of a loss of myelin due to the effects of B12 on myelin synthesis. Another dietary deficiency would be folic acid. A folic acid deficiency will produce a megablastic anemia very similar to B12 deficiency. So to tell the difference, you need a good differential diagnosis, looking at blood levels of both folic acid and B12, and also that with folic acid deficiency, you will not see neuropathy. This is only part of a B12 deficiency. Who is most likely to develop a folic acid deficiency? Basically, people with poor diets. The poor, elderly, alcoholics. Where do we get folic acid? Meat, eggs, and leafy vegetables. Another common cause of a folic acid deficiency are fad diets that eliminate major groups of food and overcooking of our vegetables, because this often destroys the folic acid. Again, the good thing is our body usually has roughly a 5-month store. So how would we get a deficiency? One would be our diet. Second would be an absorption problem, either due to disease or due to intestinal resection. Again, less surface area for absorption. Also, high demand states are a common cause of folic acid deficiency, pregnancy being one. When women are pregnant, they often are prescribed folic acid supplements to take. Growth spurts in children could result in a temporary folic acid deficiency. Prolonged bone marrow activity in an attempt to compensate for blood loss. And various malignancies. Here, the tumors would be consuming the folic acid at a faster rate than our bodies can replace it. The last cause for anemias would be a chronic disease that results in impaired erythrocyte production. Here, the bone marrow and the nutrient levels are fine, but something else is causing the problem. Some of the mechanisms involved, it could be a reduced red cell survival. Some chronic diseases result in macrophages removing the red blood cells from the blood. Could be erythropoietin. Either the bone marrow has become less sensitive to the erythropoietin and hence isn't stimulated to make the red blood cells, or the secretion of erythropoietin from the kidneys is inadequate. Secretion problems often accompany renal disease. So the underlying problem would be a renal issue that results in an anemia, secondarily results in anemia. Iron deficiency due to chronic diseases, and the diseases are consuming the iron, or marrow suppression due to tumors. Usually this is due to the production of circulating marrow suppressants by certain tumors. I'm going to shift into another cause of anemia, and these would be various forms of hemolytic anemias. Hemolytic anemia is due to destruction or hemolysis of the red blood cells. This would involve both normal and defective red blood cells. The first forms or first examples are intrinsic hemolytic anemia. Intrinsic, the problem is within the red blood cell itself. Many of these are hereditary defects that will promote hemolysis of the red cell. This often involves one of three different things: either a flawed erythrocyte enzyme system, a defective red blood cell membrane, or an abnormal hemoglobin inside the cell. One example of an intrinsic anemia is sickle cell anemia. Here the cells contain an abnormal form of hemoglobin. The hemoglobin is called hemoglobin S instead of the normal hemoglobin A. The problem is when oxygen levels become low. Hemoglobin S forms these abnormal aggregates that end up distorting the shape of the cell, creating a sickle shape instead of the biconcave disc that the cells normally look like. These distorted cells are more likely to be cleared from the blood. The body recognizes them as being abnormal. A sickle cell will only survive roughly 20 days compared to 120 days for a normal red blood cell. Sickle cells also tend to become trapped in the microcirculation. This can obstruct the blood flow to tissues and result in further damage. Sickle cell anemia is caused by a defective gene. This gene is recessive, and you can only develop the disease if both parents are carriers. And this is a very common, more commonly found in those of African origin. So here our two, mom and dad, are both carriers of the sickle cell gene. So their chances, they could have a normal child, they could have children that are carriers, and they could have one that inherits 2 copies of the recessive gene and then would have sickle cell anemia. They've often wondered, how has this gene survived through the years? One theory is that the presence of this gene provides some protection against malaria. So the people that are most protected would be those that are carriers. This person who has 2 normal genes would be prone to dying from malaria. Person who develops or inherits 2 recessive genes would die as a result of this early as a result of the sickle cell disease. Those that are carriers do not get sickle cell anemia, and they are protected from malaria. Another example of an intrinsic disease is thalassemia. This too is a genetic disorder due to hemoglobin defects. The most common forms arise from a defective production of beta globin, which is part of the hemoglobin. And this also results in an abnormal membrane. Because of the membrane, the defective membrane, these cells are cleared much more rapidly from the body. And this gene also somehow suppresses mitosis of the stem cell. So the overall number of red blood cell productions will fall. Next are extrinsic hemolytic anemia. This is due to damage of normal erythrocytes, so it's external to the cell itself. One form is immune hemolysis. Antibodies will combine with antigens on the surface of the red blood cells. This will result in very rapid clearance from the blood or in their rupture via complement activation. This is a result of transfusing the wrong blood type into a person, or the reaction that is seen between a mother and her fetus when we have an Rh negative mother carrying an Rh positive baby. Her blood, antibodies from mom's blood, can cross the placenta and attack the fetus. There are also autoimmune forms of hemolytic anemia. This is where one's immune system produces antibodies to self-red blood cells. Some cases are idiopathic, but others are due to tumors, infections, or various inflammatory conditions. This can also be triggered by drugs. What happens is that the drug will bind to the surface of the red blood cell, and this will target the cell for lysis. Another cause could be mechanical hemolysis. This is where trauma or physical injury damaged the red blood cell membranes, resulting in hemolysis. This could be due to older artificial cardiac valves, rigid aortic valves, hemodialysis machines, heart-lung machines, and prolonged trauma to the soles of the feet and to the palms of the hand. Now we're going to shift into looking at some of the other problems. We were anemia, which is low red cell count. Now we're going to shift into polycythemia, which is an increased red cell concentration in the blood. Now this could be due to one of two things. It could be due to an increase in the actual numbers of red blood cells. This is known as an absolute condition because it absolutely is due to too many red blood cells. Or this could be the result of a reduced plasma volume. Here the red cell numbers are normal, but they appear to be elevated because there's less overall volume. This is known as a relative condition. We're going to start with the absolute conditions first, where it truly is the result of overproduction of red blood cells by the bone marrow. So their numbers truly are elevated. There are three forms or three types: secondary polycythemia, primary absolute polycythemia, and polycythemia vera. Secondary polycythemia, here the bone marrow activity increases due to elevated renal output of erythropoietin. What could cause this? It could be a physiological response to tissue hypoxia associated with certain lung and heart conditions that interfere with the normal oxygenation of the blood. So the tissues aren't getting the oxygen supply they need. This will trigger an increase in the production of red cells. Exposure to high altitudes. When we travel to places of a higher altitude, there is less oxygen in the air, and this will make the body feel hypoxic and will lead to an increased production of red blood cells. Various tumors. Some kidney tumors can result in excessive secretion of erythropoietin. Other non-renal tumors can secrete materials that behave like erythropoietin and may result in bone marrow stimulus. Another cause could be restricted blood flow to the kidney. When the kidney isn't receiving adequate blood flow to maintain filtration and urine production, it figures that the rest of the body is in the same state. So the kidneys will release more erythropoietin, and this will stimulate the bone marrow to make more red blood cells. And lastly, in heavy smokers, carbon monoxide binds to hemoglobin, and this will result in a decreased oxygen delivery to the tissues. This too will trigger the renal sensors, and they will respond by increasing the amount of erythropoietin. Carbon monoxide binds to the same site on hemoglobin that oxygen binds to. When carbon monoxide binds, it binds stronger and tighter, and this prevents the oxygen from being able to bind. Next is primary absolute polycythemia. Here, the bone marrow stem cells are proliferating without any extra stimulation from erythropoietin. This typically is actually a benign tumor of the bone marrow that results in this increased production. This will result in elevated tissue oxygen levels, and which will ultimately then suppress further secretion of erythropoietin. And the third absolute form is polycythemia vera. This is characterized by thickened blood. Now you get this sluggish flow through the small blood vessels, and this promotes coagulation. This can quickly lead to tissue destruction and tends to have the greatest effect on the liver, the kidneys, and the spleen. This form is an idiopathic disease that is more commonly seen in males between the ages of 60 and 80. Our last form of polycythemia is a relative condition. Here, the number of red blood cells are normal, but the plasma volume is reduced, so this makes it appear that they are elevated. This could be due to dehydration, severe burns, or diarrhea. This is also common in heavy smokers and also in times of stress. Now we're going to look at some of the other formed elements, specifically the white blood cells. Look at leukopenia. This is a deficiency in white blood cells. Most cases of leukopenia involve a depletion of the neutrophils. This is known as neutropenia. The neutrophils are the type of white blood cell that is present in the greatest numbers. Normal neutrophil count should be between 1,800 and 7,200 cells per cubic millimeter of blood. Neutropenia would be when sustained counts are less than 1,800. And then if counts drop even lower, in extreme cases, it is known as agranulocytosis. This is when the counts drop below 200 per cubic millimeter. Causes of leukopenia could be bone marrow suppression, where the marrow is unable to produce enough neutrophils due to some type of suppression. Chemotherapy and radiation therapy, both common for cancer treatments. With these, the number of neutrophils decrease with increasing doses. Other drugs not related to tumor therapy can have an effect on the neutrophils. These drugs are much more unpredictable, and neutropenia is an unexpected side effect. Examples would be certain antibiotics can lower the number of neutrophils, anticonvulsants, as well as antihistamines. It could be due to marrow replacement by tumor growth. If you have the tumor, it's going to prevent the bone marrow from making the white blood cells. Different infections can have an effect on suppressing the bone marrow. Folic acid and B12 deficiencies for the same reason that it affected our red blood cell numbers. Genetic immune defects that would affect the neutrophils. And lastly, rapid clearance of neutrophils from the body. This could be due to an autoimmune effect, might also be due to drugs that bind to the membrane of the white blood cells and then target them for phagocytosis, or it could be due to hypersplenism. The spleen is like a sponge, so there's excess clearance of these neutrophils by the spleen. What are the effects or the consequences of not having enough neutrophils? One of the biggest is an increased risk of infection due to a decrease in phagocytosis response. Neutrophils are our first responder when we have an infection, and they come in and they begin to phagocytize the causative agent. When we don't have enough, we are at an increased risk of infection. You can also see malaise, fever, weakness, and fatigue. You'll begin to see an increase in very common infections of the pharyngeal mucosa and the oral mucosa. And in more severe cases, massive systemic infection can occur without treatment. The other extreme is leukocytosis. This is elevated numbers of white blood cells. So the count could be due, increased numbers could be due to an increased demand, and which ones and how far they are elevated often depends on what the condition is, what the demand is, and what the individual defense role of these white blood cells are. Looking at the different classes, an increased number of neutrophils is known as neutrophilia. This is often seen with acute inflammation. And in these conditions, you can see upwards of a 2 to 3-fold increase in the number of circulating neutrophils. Basophilia is an increase in basophils. This is commonly seen associated with different lung malignancies and myeloproliferative diseases, which are abnormalities of the bone marrow. Eosinophilia are an increased number of eosinophils. This is commonly associated with allergies, various parasite and fungal infections, sarcoidosis, which is a lung inflammation, and different skin disorders. Monocytosis is an increase in monocytes. This is seen with collagen vascular diseases such as lupus and rheumatoid arthritis. It's seen with chronic infections such as tuberculosis and intestinal inflammation, Crohn's, and ulcerative colitis. And lastly, an increase in lymphocytes, lymphocytosis. This is seen often with acute viral infections as well as chronic infections such as tuberculosis. We're going to end with various bleeding disorders, but again, before we get into them, we need to be aware of various terms. Petechiae. This refers to small, fine pinpoints of hemorrhaging in the skin or on post-mortem organ section. These are the result of ruptures in the small arteries or capillaries. Purpura. This represents larger areas of bleeding seen in the skin, and the areas are often less well defined. An ecchymosis. This refers to a very large area of bleeding, often known as a bruise. The changes in color of a bruise is related to the changes in hemoglobin release from the red blood cell. So you can watch the color change of a bruise, and basically this is the healing process. Bruises start out black and blue. That is the blood in the tissue. They then transition to almost a greenish color. This represents the initial breakdown of the red blood cells and the release of the hemoglobin. Then the bruises transition to a yellowish color. That is the breakdown of hemoglobin and the bilirubin release. And the bilirubin is what causes the yellowish color. And then lastly, a hematoma. This is a large volume of blood trapped in a soft tissue. This can be a very serious problem, especially if it involves the brain and compresses on the organ. Bleeding disorders could be the result of platelet disorders. Thrombocytopenia. This is an insufficient number of circulating platelets. Bleeding will then result due to minor trauma or minor vascular pressure, often manifesting as petechiae and purpura. Some causes of thrombocytopenia could be radiation therapy, chemotherapy, therapeutic drugs, or tumors of the bone marrow. These first four tend to result in a general marrow suppression. So not only will platelets be decreased, but so too will red blood cells and white blood cells. Could also be the result of thiazide diuretics, gold, phenylbutazone that's often used for arthritis, certain antibiotics, chronic alcoholism, because ethanol will suppress, chronic ethanol use suppresses the bone marrow. Congenital defects, this is relatively rare, but it too acts by suppressing the bone marrow. And then dietary deficiencies of B12 and folic acid, which inhibit DNA synthesis. Again, it inhibits the platelets for the same reason it also interferes with red cells and white cells. Another cause could be excessive clearance of the platelets. One cause here could be immune-related destruction. This involves antibodies or antigen-antibody complexes binding to the platelets. When this happens, it targets them for phagocytosis by the macrophages. An example of this is idiopathic thrombocytopenic purpura. You will see petechial and purpura blood loss in both the skin and the mucous membranes. There are two types of ITP. Acute ITP is common in children, usually following a viral infection. Most cases of acute ITP usually resolve themselves in a few weeks to several months with little consequence. The chronic form of ITP is more common in adults, especially women. Here, there is no prior infection involved, but it may occur along with lymphomas or associated with lupus. Drugs can also cause thrombocytopenia via an immune mechanism. Some of these drugs include thiazide diuretics, quinidine, and heparin. What happens is that the body makes antibodies to the drug, and then these complexes end up binding to the platelets. And then another example is thrombotic thrombocytopenic purpura. Here, antibodies are made that damage the endothelial lining of the blood vessels, and this will result in platelet adherence. This is what we talked about in the coagulation chapter. When that endothelium is damaged, it exposes the underlying collagen, and platelets will stick. So now you get a widespread coagulation in these small blood vessels that have been damaged by the antibodies. These platelets are involved in these random clots. They will not be available when there is actual bleeding. Platelets can also be destroyed by non-immune mechanisms. An example is disseminated intravascular coagulation. This causes widespread systemic coagulation and again removes the platelets from the blood. So now the platelets are involved in these random clots, and when we need them, there aren't enough available. Hemangiomas and benign tumors in the blood vessel also result in platelets binding to the epithelial surface, ultimately reducing their numbers in the blood. Protozoan infections often damage the platelets so they don't respond properly. And splenomegaly, which is an enlarged spleen. As I said before, the spleen is like a sponge. It will take up and store these platelets. The more that are stored, the less we have in the general circulation. This is commonly seen in liver conditions such as cirrhosis, and it can also be associated with congestive heart failure. Another cause of thrombocytopenia could be impaired platelet function. This involves an altered platelet membrane. When this happens, the platelets cannot bind to the damaged area and form a plug. So bleeding will occur even though the platelet numbers are okay. This could be due to genetic problems, which are relatively rare. More commonly, it's the result of acquired conditions. It could be a bone marrow tumor. It could be an abnormal megakaryocyte. This is the precursor cell that gives rise to the platelets. High doses of penicillin have been shown to alter platelets, and renal dysfunction, which causes the buildup of toxins in the blood, and these cause the damage to the platelets. Last thing to look at are some clotting factor disorders and other causes of bleeding. Here, these clotting factor disorders can result in bleeding even when platelets are functioning properly. Again, all you need to do is remove just one clotting factor from the cascade, and you will be unable to form a clot. One of these disorders is known as von Willebrand's disease. This is a genetic disorder due to a deficiency in VWF. This prevents the platelets from binding to the endothelial surfaces at the site of damage. Remember, the VWF is bound to the collagen, and the platelets have receptors for the VWF and will bind. So this prevents the platelets from binding. Symptoms will include gastric and intestinal bleeding and excessive menstrual bleeding in women. Treatment would be transfusions of VWF from normal blood donors. Another genetic condition is hemophilia. Two common types of hemophilia involve defects in either clotting factor number 8 or clotting factor number 9. The genes for these two factors are found on the X chromosome. This is why males are affected more frequently than females. They only need to inherit one defective gene, whereas women need to inherit 2 copies. Symptoms include hemorrhaging after minor trauma, severe bleeding even after minor injuries, bleeding into the joints, resulting in fusion of the bones over time. Treatment, again, would be transfusion of the deficient clotting factors from normal donors. There are also acquired clotting factor disorders. One cause could be impaired hepatic synthesis. Most of these factors are made in the liver, so any form of liver disease could result in abnormalities. This is seen in cirrhosis, vitamin K deficiency. Also seen with antibiotic therapy. Many antibiotics kill the microorganisms in our large intestines. These organisms are responsible for producing vitamin K for our use. They tend to make the majority of our vitamin K, so we don't require as much from our diet. And then another cause could be obstruction of the bile ducts. This will inhibit the absorption of vitamin K. The absorption of vitamin K is dependent on the bile. Another example is disseminated intravascular coagulation. This involves the same mechanism that affects the platelets. This coagulation, random formation of blood clots, also reduces the clotting factors. So these clotting factors are tied up in these random blood clots, and less are available when bleeding would occur elsewhere. And finally, anticoagulant therapy. This results in excessive bleeding in roughly a third of all patients receiving therapy. You will see bleeding into the GI lumen, skin ecchymoses, and hematoma. The drugs that are used as anticoagulants, the more common ones, heparin, warfarin, and Coumadin, are all susceptible to causing this. This is why people receiving these therapies need to have routine blood work done.